episode of EMClasses Board Review. Today we're going to be talking about toxicology and some environmental exposures. This is our second volume, and I'll be your host, Farhad Aziz. Alright, so the topics that we're going to be covering today are going to be reptile bites, mammalian bites, lightning strikes, some of the important insect bites, Tylenol toxicity, opiate toxicity, and aspirin toxicity. So reptile bites are going to be our first thing. And one of the big important things to remember is going to be that you have two families, your crotolid families and your elapid families. Now, your crotolids are going to be your pit vipers. And these are going to be the ones that have more of your localized wound issues, necrosis, compartment syndrome type deals. And your severity is going to be, the snakebite severity is going to be one of the main factors as to whether you give your crofab or not. Things that affect your severity score are going to be whether the signs are localized or systemic. Do you have any coagulation abnormalities? And your symptoms can typically start worsening in 6 to 8 hours, sometimes even 12 hours. So the patients that come in with a dry bite, or what appears to be a dry bite, you just have the two fangs there, and after 6 to 8 hours they don't have any change, these patients can probably go home without crofab, without any significant monitoring necessary afterwards. But your patients that have minor bites or more severe bites will, depending on what their score is, and there are different scores out there, will get crofab. Now, if these patients get crofab, they'll likely be admitted to be monitored for compartment syndrome and worsening coagulation abnormalities, DIC type stuff. And those patients that have minor bites that don't get crofab will end up being discharged home. Now, elapids is a different family. These are going to be your coral snakes. A couple things to remember is going to be red on yellow, kill a fellow. And then there's the one for not killing one that I don't remember what it is. But your signs of envenomation can be delayed up to 12 hours. And that's key because a lot of these envenomations your symptoms are going to be altered mental status, cranial nerve abnormalities, and worse, respiratory paralysis and death. So these patients get admitted regardless because they have a potential to be dead in 12 hours. So you want to make sure that you don't miss that. So always differentiate whether this was a coral snake or if this was a pit viper. And then based on that's going to be one of the main factors that determines whether this patient gets admitted or not, depending on what it is. So again, we talked about it, crotolids, elapids, antivenom. Your main question here is going to be, do you give antivenom? Do you not give antivenom? Does this patient get admitted or does this patient go home? Mammalian bites, that's going to be the next important factor. Human bites, dog bites, and cat bites are really the only ones that matter. Do you give rabies vaccine or rabies immunoglobulin, or do you not? Depending on what the patient's recent vaccinations were. So human bites, the main bacteria that you need to know is going to be Eikenella, but it's also important to know that most of these are going to be polymicrobial. Make sure that you inspect all these wounds for foreign bodies, tooth fragments, things like that. Your face and your neck and your head get sutured, primary closure with antibiotics. Everything else gets secondary closure. Antibiotics for all human bites. Dog bites are a little bit different. You can actually close most bites unless they're on your hand. And if your bites are greater than 12 hours old, then they get secondary closure. And all of these get antibiotics as well. And then finally, your cat bites. Your cat bites, know that the main bacteria is going to be Pasteurella. You want to close bites on the face again, but any bites on the hands, arms, you want to leave open. The secondary infection that you want to worry about with with cats is Bartonella Hensley. Things that tip you off to Bartonella Hensley is going to be somebody who gets bit or scratched, and then develops regional lymphadenopathy. And after you have regional lymphadenopathy, and that's going to be unilateral usually, that's going to tip you off to that diagnosis. Now, do you need to treat these with antibiotics? Yes, for any severe disease, you do treat with antibiotics. Minor diseases are going to actually resolve spontaneously over a couple weeks to a month or so. So the pearls are going to be human bites, Eikenella, Pasteurella for human bites, Pasteurella for cat bites, and then cat scratch disease, Bartonella. Most of these get antibiotics. And then finally, your do you close, do you not close is also very important. Electrical injuries. This is actually very, very key. Electrical injuries are a little bit complex because you have to kind of think about a lot of different factors. So what kind of questions are they going to ask you about this? Questions are going to be disposition. Do they come in? Do they go home? Do they need to be monitored? Is this high voltage? Is this low voltage? For lightning bites, do you do CPR? Do you not do CPR? Things like that. So let's talk about electrical injuries in general. Your resistances are going to be key. Your nerve, blood vessels, mucosal membranes, and muscles have less resistance than your bone, tendon, and fat does. What does that mean? What it means is that the less resistance, the greater the conduction. Life-threatening complications from electrical injuries are respiratory arrest, cardiac arrest, massive rhabdomyolysis, and renal failure. They may ask you the question, is AC worse than DC or vice versa? The answer is AC is actually worse than DC, and the reason for that is that AC actually causes tetanic contractions, which leads to prolonged exposure to the electrical current. What is high voltage? High voltage is anything greater than 1,000 volts, and then anything that's high voltage gets emitted. Anything that's low voltage or asymptomatic can be discharged home without observation. And local wound care is important. And just remember that the wound is going to appear less severe on the surface than it actually is underneath. You get a lot of underlying damage with electrical injuries. There's a couple specific points that I want to mention. Lip burns. These do not get debrided. Just give them some sort of petroleum-based antibiotic and follow up with plastics or oral surgery in about a week or in about a couple days. The thing that you want to watch out for is delayed labial artery hemorrhage. So any bleeding at the corners of the lips are going to be subjected to delayed labial artery bleeds. So again, do not debride and give them a petroleum-based antibiotic. Lightning burns is another thing that we need to worry about. Now, typically, this is a huge amount of electricity over a very, very short period of time. Your typical scenario is going to be an unconscious person with clothes that are partially burned. Okay, they may present with like a fern-like pattern on their burn pattern on their back. They may present in cardiopulmonary arrest, and they may have immediate or delayed cataract formation, fractures, or burns. Even if you have multiple victims, these patients get resuscitated even if they're dead. Even if they're in cardiac arrest, they still get resuscitated. Why is that a big thing? We always resuscitate patients if they're dead. That's kind of our shtick. But remember that in mass casualties, you have that grading system: green, yellow, red, black, for patients that triage classification to determine which patients will benefit from resuscitation in the field, in the hospital, or patients that you should just leave because there's nothing that you can do to help. Typically, lightning burns would end up with a black tag, but that doesn't matter in lightning burns because you still resuscitate them. Other things to concern is continue managing the burns, and all of these patients should be admitted. And this is kind of your electrical / lightning injury pearls. Your electrical burns, remember the labial artery bleeding. AC is worse than DC. You worry about arrest and rhabdomyolysis. And lightning strikes, remember to resuscitate even if they're in arrest. Insect bites, we're going to talk about 3 insect bites today. It's going to be brown recluse bites, black widow bites, and scorpion bites. Brown recluse are crafty. That's the best way to think of them, because you're not going to feel the bite. It's going to be something where you notice the wound later. These are brown spiders with a fiddle shape on their back. Typically, you get local signs of tissue necrosis, and systemic signs are likely secondary to allergies. How do you treat them? If they have necrosis, then you do local wound care, sometimes debridement if necessary. They may ask you, and they likely will ask you, whether you give these patients antibiotics prophylactically. The answer is no, only if there are signs of infection. Black widows, those are your spiders, black spiders with the red hourglass shape on their thorax. These can cause localized dull cramping sensation at the bite site, as well as localized diaphoresis. But more distressing is going to be your severe abdominal and chest pain / cramping. Now, how do you manage these? You're going to do localized wound care also, but more typical is going to be your narcotics and benzos for your pain control. These patients can go home. Morbidity and mortality is very low with these. It's going to be mainly pain control, and after a few hours, your symptoms will go away. Scorpion bites, there's a grading system, grade 1 through 4. Grade 1 is localized pain and paresthesias. Grade 2 is going to be pain, paresthesias distal from the site. Grade 3 is going to be cranial nerve or somatic neuromuscular dysfunction. And grade 4, I meant grade 3 for the last one. Grade 4 is going to be cranial nerve and somatic skeletal neuromuscular dysfunction. So first is somatic for grade 3, skeletal neuromuscular dysfunction is going to be grade 4. And then management is going to be symptomatic treatment. All patients get wound care and tetanus vaccine and toxoid. And then consider antivenom. All right. So again, these are our pearls for your insect bites. The next topic is going to be radiation injury. Radiation injury, there's basically one thing that you need to know for this, and that's going to be that last bullet point. Best predictor of survival is your absolute lymphocyte count at 48 hours. Radiation ultimately leads to DNA and RNA breakdown. The higher dose of the radiation, the sooner you'll have symptoms. Hematopoietic cells are more sensitive, followed by GI, and then your cranial or your central nervous system. And then the best predictor is at 48 hours of your absolute lymphocyte count. So what's a good predictor? Anything greater than 1,200. A poor predictor of survival is going to be anything less than 300. And this is the main point that you need to know for your absolute for your radiation injuries is your absolute lymphocyte count at 48 hours that we just mentioned. Now we're going into the actual toxicology stuff. Acetaminophen overdose. This is going to be one of the 2 highest yield toxicology topics that you'll have. Know that you have 4 phases. Phase 1 is anorexia, nausea, and vomiting. Phase 2 is elevated hepatic enzymes and coagulation studies. Phase 3 is going to be your typical hepatic encephalopathy, multi-organ system failure, and altered mental status, which I guess goes with multi-organ dysfunction. And then your phase 4 is going to be death or your symptoms resolve. Now, your treatment is going to be N-acetylcysteine, and your toxic doses are going to be usually anything greater than 200 milligrams per kilogram. All this is based on your Rumack-Matthew nomogram. Rumack-Matthew nomogram states that at 4 hours, if your level is less than 150, then this patient does not need N-acetylcysteine. This patient does not have a toxic ingestion or toxic level of Tylenol, and can likely go home. Obviously, the caveat is that usually these patients need psychiatric evaluation because it's a suicidal attempt. But we're talking about, again, acute ingestions. And then you want to make sure that you give us an acetylcysteine within 8 hours. You can give it after 8 hours, but the benefit lies before 8 hours. All right. So your pearls are going to be Tylenol level at 4 hours, N-acetylcysteine for treatment, and then measure it on the Newmack Matthew nomogram. Opiate overdose. I honestly feel like we don't even need to talk about this, but these patients are going to have your mitosis, euphoria, drowsiness, bradypnea, and pinpoint pupils. The treatment for them is going to be Narcan. It's going to be very evident that these are your typical opiate overdose. So I don't really think you need to worry about overdose so much as differentiating opiate withdrawal from something like cholinergic toxicity, because obviously you get the abdominal pain, diarrhea, sweating, lacrimation, piloerection with opiate withdrawal, but as well as with anticholinergic toxicity. Typical thing is going to be here. It's going to be the yawning may help you differentiate. That's kind of like the pathognomonic thing for opiate withdrawal. And then your salicylate overdose. This is going to be the last slide that we talk about, but this is very, very high. Remember that respiratory alkalosis is your primary acid-base disturbance, followed by metabolic acidosis. Why do you get respiratory alkalosis? It's because of your stimulation of your respiratory center. That's followed by metabolic acidosis, and then you get that mixed acid-base abnormality. Just one quick caveat is oil of wintergreen is a salicylate, so some questions may mention oil of wintergreen instead of salicylate specifically. So these patients will present with tachypnea, nausea, vomiting, abdominal pain, ototoxicity. And severe toxicities begin with your central nervous system and can progress to cardiac dysrhythmias, pulmonary edema, renal failure, and hemorrhage. Always remember that if you're going to end up admitting or intubating these patients, be very, very careful, because that acid-base abnormality, that severe metabolic acidosis, can kill the patient when you make them apneic from your succinylcholine or whatever you're using to paralyze. Management is going to be GI decontamination, renal excretion of the aspirin, and that's going to be via alkalinization of the urine with sodium bicarb. And anybody that has like a severe metabolic abnormalities, pulmonary edema, really severe renal dysfunction is going to need to get dialysis. Also, the level that you need to worry about is going to be anything greater than 90 to 100 is going to be a severe enough intoxication that will require dialysis. Okay, and always be careful when you intubate these patients. Lastly, salicylate overdose pearls, respiratory alkalosis followed by metabolic acidosis. The level that requires dialysis is 90 to 100, and then your treatments are going to be either hemodialysis or just straight alkalinization of the urine, or both. All right, well, thank you for joining us today. We have some more content coming your way soon. If you guys have any questions, please email us at emclasses1@gmail.com. But please keep following us. Thank you so much.